Disease-modifying anti-rheumatic drugs can treat the underlying cause of your condition and reduce inflammation. They're given to people with autoimmune conditions such as rheumatoid arthritis, psoriatic arthritis, and lupus. These are conditions where the immune system, which normally fights infection, attacks the body's own health tissues. Disease-modifying anti-rheumatic drugs can improve symptoms such as pain, stiffness, and swelling. In this video, we are going to discuss the tibia and synovial membrane in rheumatoid arthritis and the use of disease-modifying anti-rheumatic drugs / anti-rheumatic drugs for treatments. The video is going to be amazing, so make sure you stick to the end. Before starting the video, be sure to smash the like button and subscribe to never miss out on any of our videos. Numerous scientific studies regarding the immune-mediated nature of rheumatoid arthritis are available. One of these is that rheumatoid arthritis is thought as an autoimmune disorder, which is now uncurable. Although the cause of the disease is still unknown, most investigators believe that rheumatoid arthritis is mostly an inflammation-related disease of the synovial membrane of joints. As the rheumatoid arthritis condition worsens as it progresses, synovium, the substance that produces synovial fluids, expand and becomes thicker, creating an increase of synovial fluid. It, by itself, can lead to additional swelling and inflammation that creates stiffness and pain in the joint. Rheumatoid arthritis is an ongoing condition, an inflammatory disorder that affects synovial joints. The theory is that neutrophils be a part of significant role in both the initiation as well as the progress of rheumatoid arthritis, and the large number of neutrophils that are activated can be found in both synovial fluid as well as synovial tissues derived from the rheumatoid arthritis joints. The tibia is one of two bones that comprise the leg. As the weight-bearing bone, it is significantly larger and stronger than its counterpart, the fibula. The tibia forms the knee joint proximally with the femur and forms the ankle joint distally with the fibula and talus. The tibia runs medial to the fibula form just below the knee joint to the ankle joint and is connected to the fibula by the interosseous membrane, the strongest one in the body. It's formed by the femur, thigh bone, tibia, skin bone, and patella, kneecap, coming together. In a healthy knee, these are cushioned by wedge-shaped pieces of cartilage. When this area is damaged by rheumatoid arthritis, the pain, swelling, and stiffness may be severe, especially after you've been inactive for several hours. Other symptoms may include difficulty bending and/or straightening the knee locking while you walk, a grinding, snapping, or creaking noise when you walk, weakness or buckling. Joint damage and deformity can be repaired by knee replacement surgery, which can also reduce pain and restore function. Rheumatoid arthritis is a systemic polyarticular chronic autoimmune joint disease that mainly damages the hands and feet, which affects 0.5% to 1% of the population worldwide. With the sustained development of disease-modifying anti-rheumatic drugs, significant success has been achieved in preventing and reliving disease activity in rheumatoid arthritis patients. The five main classes of drugs used for rheumatoid arthritis: disease-modifying anti-rheumatic drugs, corticosteroids, Biologics, NSAIDs, and analgesics, each play a different role. Some of these arthritis medications only relieve pain, some stop inflammation, and others address the disease process to prevent a flare-up of symptoms and halt disease progression. A number of disease-modifying anti-rheumatic drugs are used, and they are summarized in Table 77. Minocycline is an antibiotic that is not often prescribed, but it may help rheumatoid arthritis by stopping inflammation. It can take several months to start working and up to a year before the full effects are known. When taken for long periods, minocycline can cause discoloration of the skin. Methotrexate is the most commonly used disease-modifying anti-rheumatic drugs. This is because it has been shown to work as well or better than any other single medicine. It is also relatively inexpensive and generally safe. Like other disease-modifying anti-rheumatic drugs, methotrexate has side effects. It can cause rash and stomach upset, can be toxic to the liver or bone marrow, and can cause birth defects. In rare cases, it can also cause shortness of breath. Regular blood work is necessary when taking methotrexate. Taking folic acid helps reduce some of the side effects. Methotrexate's biggest advantage could be that it has been shown to be safe to take for long periods of time and can even be used in children. In patients with definite inflammatory arthritis, disease-modifying anti-rheumatic drugs are usually started as soon as the diagnosis has been made. They are then usually continued unless they have to be stopped for toxicity or loss of effect. In patients who are well controlled on disease-modifying anti-rheumatic drugs, stopping treatment leads to a higher high risk of flares. It can take several weeks or months for disease-modifying anti-rheumatic drugs to ease the pain and inflammation caused by rheumatoid arthritis. Therefore, in addition, other medicines are normally advised for a time to help control symptoms until disease-modifying anti-rheumatic drugs start working. These may be steroid medicines, anti-inflammatory machines, and/or other painkillers. Steroids, anti-inflammatory medicines, and painkillers ease the pain and reduce inflammation of rheumatoid arthritis. Steroids can prevent joint damage if they are given in low doses and taken over a long period of time. However, they are not usually prescribed this way anymore. If a disease-modifying anti-rheumatic drugs does not work after 6 months, then your doctor will normally change your treatment. To date, a large number of clinical trials have been performed by scientists and clinicians for testing different types of agents in rheumatoid arthritis treatment. Some of these agents have been approved for daily clinical practice. In the first place, non-steroidal anti-inflammatory drugs, including acetylsalicylate, naproxen, ibuprofen, and atodolac, are used to alleviate pain and swelling and decrease inflammation. Non-steroidal anti-inflammatory drugs exert their actions by inhibiting the enzymatic activity of the cyclooxygenase involved in the synthesis of prostaglandins. Inhibition of COX-2 by non-steroidal anti-inflammatory drug blocks prostaglandins productions at sites of inflammation, whereas inhibition of COX-1 in other tissue, platelets, and the gastroduodenal mucosa leads to common adverse effects of non-steroidal anti-inflammatory drugs, such as bleeding and gastrointestinal ulceration. In addition, corticosteroids like glucocorticoids are another kind of potent anti-inflammatory drug which modulates gene expression by binding to glucocorticoid receptors to display anti-inflammatory and immunosuppressive effects. However, their side effects include nausea, abdominal pain, ulcers, osteoporosis, and diabetes. Owing to the adverse effects of non-steroidal anti-inflammatory drugs and corticosteroids, disease-modifying anti-rheumatic drugs, a class of immunosuppressive and immunomodulatory agents, are developed to prevent and relieve rheumatoid arthritis aggression. As the first treatment strategy, conventional synthetic disease-modifying anti-rheumatic drugs like methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, chloroquine, and gold salts should not be as soon as rheumatoid arthritis is diagnosed. Notably, methotrexate is preferred for use in patients. Biologics, which are produced from living organisms, are a newer class of disease-modifying anti-rheumatic drugs. Generally engineered from a living organism, biologists target specific inflammatory cells, cellular interactions, and cytokines that cause rheumatoid arthritis-related tissue damage. In doing so, biologics help reduce arthritis symptoms and slow disease progression. Biologics are prescribed as an add-on therapy after treatment with methotrexate or other disease-modifying anti-rheumatic drugs that have failed to relieve symptoms and influence disease progression. TNFIs are the most commonly prescribed class of biologics, recommended as a second-line treatment where methotrexate and other disease-modifying anti-rheumatic drugs fail to halt disease activity. They target an inflammation-causing substance called tumor necrosis factor. Biologic therapies suppress the immune system and can make you more vulnerable to infections such as cold, upper respiratory tract infection, sinus infection, sore throat, bronchitis, or urinary tract infection. Prior to the development of more targeted therapies, analgesics were the primary treatment for arthritis pain. This class of drugs includes non-narcotic pain relievers like TINEL and opioid painkillers such as hydrocodone. Analgesics work to relieve arthritis by changing the way the body senses pain. This can be effective for short-term pain relief during a flare-up, but are not commonly recommended any longer due to the availability of more effective treatments. Sold over the counter, acetaminophen is the most common analgesic. It is found as a standalone medication or in combination drugs like those formulated for colds, migraines, and period pain. In large doses, acetaminophen can cause liver failure. Use caution to not mix products containing acetaminophen and do not exceed 4,000 milligrams per day. Opioid analgesics such as oxycodone, codeine, and morphine are highly effective at reducing pain, but cause disorientation and can be fatal if taken in large doses. Tramadol, a time-released opioid, is sometimes prescribed for moderate to severe rheumatoid arthritis pain, as it is thought to have a lower risk of abuse than other narcotics. However, addiction is still a risk with this drug. Vicodin, Lortab, and Norco are brand name formulations of hydrocodone and acetaminophen. They should be taken with Tylenol or a combination of cold medicine. Side effects of opioids include nausea, constipation, and trouble focusing or thinking clearly. The FDA has approved all disease-modifying anti-rheumatic drugs. Many people take them without ever having problems. To minimize side effects, disease-modifying anti-rheumatic drugs are sometimes started one at a time and increase gradually. The goal is to minimize both rheumatoid arthritis disease activity and medication side effects. It often takes more than one disease-modifying anti-rheumatic drugs to get control of active rheumatoid arthritis. How do you know you're on the right regimen? There's no easy way. Rheumatologists use all their training and experience to determine what's right for you. Though disease-modifying anti-rheumatic drugs can have side effects, there is a good reason to take them. They've proven to work against rheumatoid arthritis. Even if you are in remission, many rheumatologists believe you should keep taking a disease-modifying anti-rheumatic drugs just to keep your rheumatoid arthritis at bay. Let us know your opinion in the comment section below. This was all for today. Hope you liked the video. Do not forget to subscribe to our YouTube channel. Stay safe, and we'll be back soon with another video. Please click on the next video clip to watch for more health info. Thank you very much.